Hi everyone, today we're going to talk about the subject we chose for the longitudinal small group project, Barriers to Perinatal Care for Pregnant Women of Low Socioeconomic Status who are recent immigrants arriving in Quebec. We're a group in Quintal E. First of all, the magnitude of the issue. In 2024, there were 7.9 million births in Canada and about 21% were to immigrant mothers. In Quebec, immigrants make up 14.6% of the population and their share of births keeps increasing every year. Yet, about 16% of recent immigrants in Quebec live in poverty, meaning many start their pregnancies facing serious financial and social instability. Now, for the importance of this issue as a public health matter is that the group of our study often encounters language barriers, financial insecurity, and social isolation, which can lead to delayed prenatal care, fewer follow-ups, and more complications. These numbers highlight the urgent need for accessible, affordable, and culturally safe prenatal and postnatal care. Now, we chose this topic because we all come from immigrant families, and many of our own mothers experience similar struggles. This project helped us see how inclusive perinatal care can transform lives. Supporting immigrant women means breaking cycles of poverty and health inequality, and that's why this issue matters deeply to our team.
Now, before we dive into maternal health outcomes, it's important to recognize the key challenges recent immigrants face. So these women often encounter cultural and language barriers, a lack of affordable housing, as well as social isolation, stress, abuse, and some of them live with immigration status insecurity, which can make them afraid to seek care. So together, these challenges set the stage for the poverty outcomes that affect pregnancy that we'll see in the next slide. Now let's dive into our logic model, which shows all the structural barriers that impact our population. We will walk through it from left to right. So at the left, we start with the house, which represents the barriers or challenges faced by recent immigrants that we presented in the previous slide. Those barriers lead directly to poverty-related outcomes for pregnant women, including food and housing insecurity and difficulty entering the job market. On top of that, limited health literacy make it hard for them to access and understand healthcare information. Here, interventions like community navigation, free language courses, and public housing programs can reduce those first obstacles by improving integration of resources. Without support, these women might face immigration-related stress and distrust of the healthcare system, thus aggravating pre-existing health conditions and leading to failure in primary perinatal follow-up, which we see in the second problem box. At this stage, interventions such as nutritional support via food banks and translated medical pamphlets can help buffer these risks. Finally, without timely care, women are at greater risk of severe perinatal outcomes such as gestational diabetes, preterm birth, and others shown in the last problem box. But even there, the model identifies opportunities to intervene, such as specialized clinics for new immigrants like our Maison Bleue. Overall, this model shows two main points. So first, these outcomes are rooted in systemic poverty and immigration-related stress. And second, we can intervene at multiple levels to help reducing inequities and improve maternal and neonatal health.
We explored the evidence using PubMed and Google Scholar as a primary database for a peer-reviewed article. For gray literature, we consulted government's publication, including the Guide of Cultural Mediation. Systematic reviews were also used, which drew on community health worker impact on knowledge, antenatal care, and birth outcomes as systematic review. Further evidence shows that preventing immigrant women from falling into poverty in the first place requires a package of upstream measures. Here are some examples. First, child benefits can significantly reduce child poverty in Canada, but for newcomers, their impact is often weakened by barriers such as complex tax filing, limited outreach, and a lack of application support. Quebec's universal low-free child care system lowers out-of-pocket costs, support maternal employment, and increase overall family earnings. Another one is language instruction programs such as Link and Click not only supports employability but also improve navigation of the healthcare and social system. Together, these measures and others form a practical upstream strategy to prevent poverty before it even begins. To mitigate the harms of poverty, the evidence shows we need a multi-layered approach. Recognition of foreign diplomas is often long and costly, blocking access to qualified jobs. Evidence shows that community health workers, or CHWs, play a central role. They help immigrant women access prenatal consultation, adhere to follow-ups, and reduce stress and social isolation. This has been shown to improve both maternal and neonatal health outcome. On the social side, subsidized housing through OMHM caps to rent at 25% of the income reduce housing insecurity. Food support programs like Moisson Montréal are critical, but pairing them with education on the Canadian Food Guide helps prevent complications such as gestational diabetes. Finally, maternal health literacy through translated pamphlet and cultural sensitivity prenatal classes empowers women to make informed decisions.
So now we're going to talk about the evidence. So for community navigation, the evidence is moderate. We have a systemic review showing that community health workers improve maternal knowledge, increase prenatal care attendance, and can even improve birth outcomes. For cultural mediation, the evidence is weaker. What we have is more of a Quebec practice guide, which gives useful strategies but isn't backed by big outcome studies. For basic needs like housing and food, the evidence is moderate. These are policy-based supports from government programs and national guidelines that reduce insecurity and promote healthier pregnancies. And finally, for maternal health literacy, the evidence is also moderate. National public health evidence links poverty, low education, and poor health literacy as key social determinants, and improving literacy empowers women to take better informed decisions about themselves and their babies. So, what should we do to adapt interventions to this context? To help with language barriers, we should use plain, clear language that can be translated to something easily understandable for people with different cultural backgrounds. We can make signing up for care easier by making forms short and simple and have real people sit with families to help. Also, providing culturally safe care is essential and avoiding these one size fits all cultural labels. We must also protect privacy and immigration safety, especially when there's a situation of violence or concerns about status. Finally, communication between health and social services will help this transition and will help us see how the mom and baby are doing in the long term.
So now we'd like to share two stories that reflect both successes achieved and the struggles that remain for immigrant women during pregnancy. The first is Marisol, a pregnant woman in Montreal. When the pandemic hit, her partner lost his job. At 16 weeks, she suffered severe pain but was afraid to seek help because of her status. When she finally went to the hospital, she was billed over $8,000. Scared and isolated, she turned to Doctors of the World. There, a team of doctors, nurses, social workers, and translators followed her closely and supported her through a high-risk pregnancy. Thanks to them, she gave birth safely by cesarean, and now her story shows how community organizations can transform such vulnerable situations. However, on the other hand, there's Fatim, a student at Université de Laval, and she discovered her insurance excluded pregnancy and she had no RAMQ. Every step came with a cost. Hundreds for visits and ultrasounds, and even $1,000 for an epidural she had to refuse after being told by the anesthesiologist, $1,000 or nothing, madam, it's not my problem. Furthermore, with her baby not growing properly, she faced weekly hospital checks she could barely afford. Friends and compassionate clinicians helped, but she still ended up with a $6,000 bill. Today, her child is healthy, but Fatim herself remained trapped in uncertainty, burdened by debt and unresolved status. These stories are rarely public, as many women fear speaking out and NGOs protect their identities. Still, for every Marisol, there are many Fatims, reminding us that while we can celebrate progress, the gaps remain and our work is far from over.
What measure can be used to assess progress and determine success? We can go with three kinds of evaluation. First of all, the process evaluation, monitoring how the intervention is implemented allows us to see if the program actually reached the target population. As an example, we can go with community navigation and cultural mediation. We can evaluate the proportion of pregnant women with low socioeconomic status who recently immigrated and were contacted by a community worker as a quantitative indicator. A satisfaction survey can be used to assess whether the program is well defined and if the needs are met as a qualitative indicator. The second one is outcome evaluation. After about 1 year, we can compare the result before and after implementation. We can evaluate the proportion of women starting prenatal care in the first trimester, adherence to the medical prescriptions such as folic acid, iron supplements, based on the information provided by the pharmacist. And the last one is impact evaluation. In the long term, more than 5 years, success can be assessed by a reduction in health inequity, such as lower rates of prematurity, neonatal mortality, and low birth weight in the target population.
So, to wrap up, what do we take away from this? Low-income immigrant mothers in Quebec are at high risk of poverty and poor health because of barriers like financial security, language gaps, discrimination, and even unsafe sponsorship situations. The evidence is clear. Income supports and childcare helps families avoid poverty, while credential recognition, language programs, and legal protection open the door to long-term stability. What do we recommend? First, make benefits automatic and accessible. Second, expand affordable childcare and paid bridging programs. Third, simplify credential recognition and link language training to real job opportunities. And finally, protect women experiencing violence with faster, permanent residency options. Next steps fall to governments, health systems, community groups, and researchers, each with a role to play. Taken together, these actions can reduce poverty risks, improve maternal health, and give immigrant families a fair start in Quebec. These are the references we used throughout the project. Thank you so much for watching.